Welcome to this tutorial on critical appraisal and critically applied topics. So the aim of this tutorial is to get you to understand what critical appraisal is, to learn how to do this and how it's applied in evidence-based medicine techniques. All of these techniques are standardized, so we need to understand why they're standardized, and we're going to start to apply the principles of the statistics in calculators to apply them to clinical papers so that we can make a more informed decision in our clinical stop. The aims of this tutorial are to help you to understand what critical appraisal is, to learn why we do critical appraisal in evidence-based medicine and to learn the techniques involved in it, to learn why they're standardized throughout the profession, and to apply some of these principles using calculators. And this will allow us to build our own critically applied topic so that other clinicians can use it in practice. So in the previous courses, we've looked at how to do a patient intervention comparison and outcome search in more than one database. We've learned to look at the reliability of those papers once we have them, and now we're going to look at the actual results of the trials in the papers to see about their levels of reliability. This is just a funny slide that I like, that tells us how we used to be before we used evidence-based veterinary medicine. So what is critical appraisal? Well, we've got a number of articles, we've put our patient question into a database, and we've got some papers. And critical appraisal is now using a standard method of statistics in the paper's results. So now we've got the results, we can apply some statistics to them to see whether or not those results are actually reliable. So this means if we're using standard methods of statistics, the same as the rest of our colleagues, then it means that our clinical bottom line is more understandable to the rest of our colleagues because they're using the same principles. And it means that the entire process becomes more reliable and robust. And that means that our clinical decisions can be based on better scientific evidence. Now, we're not going to teach you the principles of the statistics involved in these techniques, because this will be covered in another course, and it's a prerequisite of this course to be familiar with the principles of risk, odds, predictions, likelihood ratios, sensitivities, specificities, and other of those statistical principles. But what evidence-based veterinary medicine does is it allows us to use those and make them clinically relevant to our cases. So the key concept in any statistics is the basis of risk and odds. Now, when we treat any patient at all with anything, there's always a risk that that patient won't get better. Now, maybe that's for many reasons, but if we apply it to a whole population and lots of numbers of patients, then there becomes a risk that a patient won't get better from that intervention. And that's called an event rate. So therefore, in two groups, where there's a group given an intervention and a group not given an intervention, then there's an experimental event rate in the intervention group and a control event rate in the control group. But some papers don't have a control group for welfare reasons. So when there's two intervention groups, our experimental event rate is the one with the better result. And this can be applied to both randomized control trials and cohort studies, because both of those levels of evidence papers can actually be applied to two comparison groups. Now, when you look at any best evidence website, the key decision is usually made from something called the number needed to treat, or NNT. Now, the number needed to treat is a value put to the risk of the intervention not getting our patient better. So when we're comparing two groups, there's a group where the risk is greater than the other group. So we can look at relative risk and absolute risk by looking at the event rate in each group. So there's an event rate, which is the rate at which there's a bad outcome at the end of the trial. There's a control event rate, which is a rate of a bad outcome in the control group, which is actually, if you look at the reverse of that, the indication of the number of animals that get better anyway. And then there's the number of animals that have a bad outcome in the intervention group, and that's the experimental event rate. Now, by using some simple calculations on the recovery rates, we can get NNT, which is the inverse of absolute risk reduction. Now, NNT in English is the number of animals needed to be treated by the intervention to prevent a bad outcome in a further animal. So as we can see, NNT isn't really a true number, it's a best guess. It simply states the risk of a group of animals in a population getting better or not at the end of the treatment course. Now, NNT is usually in an integer, and the lower the NNT, the better the intervention. Now, NNT isn't just the only thing we should look at, because we also need to look at confidence intervals. For instance, if a trial was done on 1,000 patients, it would be far more reliable than a trial done on 10 patients. However, the confidence intervals can be very difficult to work out and quite confusing. So therefore, there's an acceptable standard, and a confidence interval is usually of 95%. The confidence interval can be hard to work out. It's actually quite a difficult calculation. So all we really need to do is look at the group numbers to see an estimation as to how reliable that trial will be. Fortunately, that previous calculation can be put into an Excel calculator, and the program will work out the confidence interval for you. Systematic reviews review randomized control trials and cohort studies, and our meta-analysis or critically applied topic will also do this. But when we're looking at a systematic review, this is a global review of lots and lots of different trials. So they use something called a forest plot. Now, each of these blobs, this is also called a blobogram, each of these blobs is one randomized control trial. And you can see that if we looked at just the randomized control trial done in 1981 and 1982, both of those trials indicate that that drug favours the treatment group. However, if we look at the confidence intervals over all of the randomized control trials, many of those patients either side of the middle of the group fall into the favours control group, which is actually the negative NNT, or number needed to harm, so there's more adverse effects in those groups. So actually, as a result of this systematic review, the drug was pulled from the market. So just to remind ourselves, a negative NNT is termed number needed to harm, and that actually means that the intervention group is worse than the control group. So another type of intervention is a diagnostic test. We've already covered this in the epidemiology course, so we should be familiar with sensitivity and specificity, and positive predictive value, negative predictive value, true prevalence, apparent prevalence, likelihood ratios of positive and negative. But essentially, all of these are based on 4 numbers. Now, in evidence-based medicine, sensitivity and specificity is termed spins and snouts. Just to help you remember which they are, then specificity, you always rule a positive in, and sensitivity, never rule a negative out. So as I said before, all of those calculations are based on 4 numbers. There's the number which tested positive out of the group, and the number that actually tested positive, and the number that tested negative as opposed to the number that were actually negative, and the total in the trial. If we can then work out those in an Excel calculator, it will give you all of those numbers and do all the maths for you. As I said, evidence-based medicine isn't about you crunching through the calculations, it's about you understanding the results and making a best evident guess on whether or not the diagnostic test is reliable. So a calculator can really help us in choosing and making our clinical decisions. Now, a critically appraised topic is when we've done the entire process of the last 3 years. So we've asked a patient question, we've looked at databases, we've got some papers, we've looked at their results, we've applied standardized statistics, we've looked at how reliable those are, put them all together and concluded with a clinical bottom line. Now, the clinical bottom line could also state what the study weaknesses were and what could be improved in future research. And if we could feed that back to the drug companies, we would have a far better stand as clinicians in years to come, because we could direct the clinical research that's done. So once we've got our critically applied topic, we can have a cat club. So we can review each other's cats, either online or as a group. So in this tutorial, we've looked at the standard way of approaching data. We've learnt why there's a standard way, because other clinicians can understand what we've done. We can apply some statistics to the results in the papers, and we can summarise the statistics and make a best evidence guess as to what our clinical decision should be. So to summarise, these are some good books to look at to teach you how to do evidence-based medicine in practice. And there's some really good websites here that are all to do with explaining some statistics in critical appraisal and how to help you through confidence intervals and p-values.